Okay, we're live. Hi, this is Elliot Fishman, and welcome to our weekly Facebook Live. It's December. I think today's December 2nd, if I can get this right. Yep, it's December 2nd. Hope everyone had a great Thanksgiving and everyone's looking forward to the New Year and the Christmas break. And those of you who are Jewish, you're in the middle of Hanukkah. Today's day 4. Tonight's the 5th candle. So I hope that's going well. The halfway mark of 8, right? Um, this week, Lily told me or reminded me that it's Crohn's disease or inflammatory bowel disease week. So I thought we'd speak about inflammatory bowel disease, about Crohn's disease, and the role of CT imaging in inflammatory disease. So one of the things, when you look at the history of CT, one of the earliest applications of CT was for inflammatory bowel disease. And I published a paper with Ed Wolf and a few other people many, many years ago looking at the role of CT in Crohn's disease, looking at its role in detecting the extent of disease as well as complications. And CT was proven to be very important in terms of management. Patients with Crohn's disease are difficult patients, there's no doubt. It's a terrible disease. And they show up to the doctor numerous times during the year. The challenge for the physician taking care of these patients, and they're very good physicians, is how to manage the patient. Most patients with conservative management will do really, really well. Some patients will end up needing surgery. The thing is, you would like to avoid doing surgery because surgery has its own complications. So you really want to figure out how can I best treat that patient? And when do I need to do surgery, when do I not? And I don't want to do imaging, whether it's CT or MR or fluoro or plain films. I don't want to do that all the time. So what can I do? So one of the things that CT is very good at is very good at triage. So the question is, sometimes we do abdominal pain. Is there inflammatory bowel disease present? CT is really good at looking at the small bowel. Now, what do we look for in the small bowel? We look for wall thickening. Now, excuse me, I do have a cough. My grandchildren, Max and Sam, visited me last weekend and they came with runny noses. So, of course, I got their cold. On Sunday, I felt a little bad. Monday, I was sneezing. Tuesday, I had a sore throat. Wednesday, I had a raspy voice. And today, I'm coughing. So, I'm almost better. I did take my COVID test times 2. So, there's no issue. And the kids also had COVID tests before they came. So, no COVID. Okay, so let me just say that. And in looking at techniques for doing inflammatory bowel disease, we always like to use IV contrast. IV contrast really enhances areas of mucosal abnormalities. It shows areas of stricture better. It shows areas of active disease by hyperenhancement. It shows things like the vasa recta, so you can see the comb sign for active disease. We also spend a lot of time looking at the mesentery in addition to the bowel. We also give oral contrast. Now, we used to give positive oral contrast, but when you give positive oral contrast, as we all know and we've spoken about many times, it's very hard to look at the mucosa. So you want to give neutral agents. Volumen is, people don't like volumen. We've been trying this Breeze agent, which seems pretty good, but most of the time we simply use water. That works very nicely. Surely in a patient with bowel obstruction or partial bowel obstruction, they have a lot of water in place already, so that works out very nicely. So with Crohn's, I like to do dual phase imaging if possible. If not, I'll scan at 70 seconds, do a single phase. I'll look at the liver and spleen and kidneys. Patients get increased incidence of renal stones and infection. I'll make sure there's nothing going on in the liver or spleen. I'll look carefully at the bowel. I'll also look carefully at the stomach. Remember, Crohn's commonly is small bowel distal, but can be proximal from the duodenum to the jejunum. Crohn's can also involve the stomach, though it's less common, but it can present with an infiltrating lesion of the stomach, can cause symptoms. Excuse me. I'll then look at how the bowel enhances. The wall should be less than 3 millimeters thick. Is it prominent enhancement? Are the vasa recta really prominent branching off the SMA? So you have the comb sign. Is there a transition present? Is the dilated bowel only distally, or is it multiple areas with skipped segments? is usually ileum, but it can be the large bowel and small bowel. I'll look at that very carefully. Sometimes you're looking just abdominal pain and it's hard to tell Crohn's versus UC, particularly when it's large bowel only. When it's very extensive large bowel, it's typically ulcerative colitis and not Crohn's disease. We also look carefully in the patient with Crohn's at transitions over time, how long the area of narrowing is, how severe the narrowing is. The surgeons will typically use that information to decide whether or not they want to operate on a patient. Again, everyone is trying not to operate on patients, but sometimes you need to, and the CT can be very valuable in telling you that information. Now, one challenge with Crohn's is an increased incidence of carcinoma in Crohn's disease patients. Sometimes you can see a bulky mass, and that makes it fairly easy, but I just saw a case the other week where there was some thickening of the bowel. It looks just like Crohn's, long segment disease, and it came back on path, high-grade dysplasia, so concerning for neoplasm. And I've seen other cases where we simply look and say, okay, the bowel is diseased, there's no doubt about it, patient has Crohn's, there's severe narrowing. But there's been cancer present. So, excuse me. So anyway, that's one of the things we will look at. I'll also look complications like stone disease in the gallbladder, stone disease in the kidneys. I'll look at the mesenteric inflammation. It's one of the things I look for. So the number of things I'll scan down to. Patients with Crohn's can also get perirectal fistulae, so I'll look very carefully at scans through the pelvis. So I'll scan low enough. Patients with Crohn's can also develop GI bleeding. Though it's not that often we see patients present with GI bleed, rule out a cause, and the cause is Crohn's. But you can see prominent mucosal enhancement, and so it's an important application. People also use MR enterography. The advantage of MR, of course, is no radiation dose. CT is higher spatial resolution, and it does a better job, but in patients who get multiple scans over time, there's no doubt MR may be very helpful in that regard. Remember the old days we did lots of fluoroscopy. Now typically fluoro is not done. Every once in a while fluoro is done if you're looking at fistulas, but CT, if I'm looking for a fistula, let me just say then I'll use positive contrast. With Crohn's, it's not uncommon to get enteroenteric fistula, usually multiple small bowel loops can tether. Usually I can make the diagnosis even with water as a contrast agent, but if you really want to see fistulous tracts or you want to see perforation, then positive contrast is something you want to be doing. As I mentioned, we'll look at the entire GI tract from the lower esophagus, the GE junction, through stomach, small bowel, and colon, make sure there's no disease in any of those areas. And then look at the other associated organs, liver, spleen, and kidneys are the ones that come to mind the most. Now, in terms of some of the new things that people are looking at, we have been looking at cinematic rendering, which is really good at looking at bowel inflammation. Can we predict and grade bowel inflammation? Can we predict better what patients are going to obstruct, what patients can be managed conservatively, and which ones can't? I think clinicians will often, again, the goal is to try to be conservative management, but sometimes you need to operate, so you'll operate. But again, I think that often is that's a clinical decision in many cases. Also, it's a clinical decision between the patient's physician and the patients. Again, patients don't want the surgery. You get adhesions from surgery and more complications, but sometimes surgery is necessary. We also are careful about interloop abscesses, perforations, fistulae. We also look carefully at the bone. Patients are often on steroids, so you look for avascular necrosis of the femoral heads. They often get sacroiliitis, so you look at the SI joints, you look for sclerosis, erosion, as well as narrowing and fusion. So inflammatory bowel disease is multi-organ, and you want to look very carefully and make sure there's not other important findings with you. So again, look at the axials, scroll through everything, but then coronal and sagittal look great. Look at the mesenteric vessels. The sagittal is very important for that. And then I will do 3D imaging. I can do a really good job looking at with volume rendering at the bowel, but cinematic rendering does seem to take on a life of its own when looking at the bowel. So those are some of the main things I wanted to speak about. I'll be happy to take any questions. Let's see. John Biacchino's here. He's from home again. So if you follow us on Facebook Live, you would think John must live at home. Now, John works here most of the time, but he always seems to be home on Thursdays. I guess that's his day to be home. And, you know, I guess maybe soon, you know, Siemens is showing how they can have people scan remotely. So, you know, people can scan the patients when you don't have a tech. So maybe our tech someday, like the doctors, will scan remotely. So what a world. Someone gets the patient on the table, the scan is done by the tech remotely, and it's done by the radiologist reading the scan remotely. The billing is done by the billing people who are remote. The only person who's there is going to be the patient. And in the future, you can imagine that the scanners will be small, will be like the size of my mouse, and it'll be like kind of like Star Trek, where it'll just wave the wand over you, and it'll come up with an answer, and then you could read the films and do everything else and use AI. But I would not hold my breath exactly for that coming. But if you look at companies like NVIDIA, it's not hard to imagine. And then there's another one of our techs, Jay Jamie. He's saying hello from Glen Burnie. So John's in Timonium. Glen Burnie is the other way, down toward Annapolis. When you're in Maryland, if you go south, like you're going to Washington, Glen Burnie is kind of on the way there, to the side a little bit, going south from Baltimore. And Timonium, those who don't know anything, Timonium is kind of northwest. So you leave Baltimore, go up to northwest, Towson, Timonium, Owings Mills, Stevenson, which is kind of where I live. So that's your Baltimore geography for today. Other than that, just to make several announcements. One is I have a whole bunch of new lectures on CTisus this last 6 months through the beginning of the year. All our lectures are brand new lectures. It's not like it's upgrades of lectures, which I'll be doing a lot more next year, but there's about 25 out of 26 lectures that I've never given before. Put a lot of effort putting them together, so hopefully you like them, and I'm working on many more based on many of the suggestions people have. We're working on our new quizzes for 2022. That'll be out January 1st. We're working on new quizzes. We're working on this incredible app, which is essentially at the Apple Store, just some final touches on the lumbar spine. Everything you want to know about the lumbar spine, but we're afraid to ask, focusing on the lateral view in CT. So that's just a tremendous app coming along momentarily. It's going to be there momentarily, the new revised. And there was a version before, but this new revised version is particularly good. Really high tech, and I think you will really like it. We are also working away at upgrading some other apps the end of the year. The CTisus lecture series will be updated with 6 months more. The CTisus iQuiz will be updated with 6 more months of quizzes, 72 quizzes. Usually it ends up being about 600 to 700 per roll, so massive influx of material will continue. And with that, if I have no other questions besides people telling me where they live, I'll call it a day, and I'll go back to read some films, and I'll let you guys go back and read films or scan patients or watch the grass grow or anything you want to do. If you want to have a few laughs, if you have HBO Max, watch Larry David, Curb Your Enthusiasm. Also, it's a bit slow, but it's really impressive to watch Let It Be. You know, it's 3 episodes of 2 hours plus. It's a little bit tedious and painful in the beginning, I have to admit, but it gives you the great understanding and workings of the group. And I think at the end, you'll have a lot better feel for Paul McCartney, because if it wasn't for him, there was no group at that point. And it's interesting how people who are very successful can fall apart. But, you know, I think different times they probably would have stayed together or got back together. It was just nobody was managing the relationship. So it's a sad story, but there's some mighty, mighty good music, and it's impressive because the way the show goes is they cover the creating of the Let It Be album, also some of the Abby B stuff from start to finish. It's just an amazing bunch of creative people doing incredible things. Oh, so many years ago. That was 1969, 50 some odd years ago. When you look at the quality of the video and the audio, it was just spectacular. So I think that's on HBO as well. So, or maybe Disney. I don't know. Maybe, I don't know. But it's one of those channels. But if you don't have HBO, you can go on YouTube. There's a million snippets. They're like 3 minutes long, a million snippets. If you don't have HBO Max and you can't get Larry David, go on YouTube. There's a million different snippets. I fell asleep. I wasn't feeling well on the Monday show, which is always Sunday night, but I was going to watch it Monday because I was under the weather. But I didn't get to it. But then I watched the next couple of days all of these 3 minute little things. I watched more of them. So when the time I watched the show, I had seen everything. But gives you something to do with your time if you're not busy. And Jay's watching Bluey. I watched Bluey like 4 hours a day over the weekend. Bluey is my favorite. Anyway, I got every paraphernalia that Bluey makes, from blankets, the houses, the cars. I know all the kids from Mackenzie to Snickers and God knows what. Anyway, with that, have a great day, and I'll see you next time. Bye-bye.